I want you to stop whatever you are doing right now. Extend your hands in front of you and look closely at your fingernails. I am not talking about checking your manicure, looking for a hangnail, or seeing if they need trimming. I mean a deep, analytical look at the actual surface anatomy, the microtexture, the depth of the ridges, the geometry of the curvature, and the precise color transition at the very base of the cuticle. Most adults over the age of 60 have never truly looked at their nails from a clinical perspective. They have viewed them as dead tissue, purely cosmetic fixtures at the ends of their fingers. But as a medical professional, I look at your hands and see an exposed, live-streaming biometric dashboard. Your nails are directly tethered to your deep peripheral vascular network, your autonomic nervous system, and your metabolic core. Right now, as you read this, the surface of your nails may be displaying the earliest structural warnings of internal dysfunction that your brain, your kidneys, your liver, and your circulatory system have been quietly screaming about for months or even years under the surface. My name is Dr. Liam Cooper. I have spent more than 2 decades embedded in the fields of clinical neurology and systemic diagnostics, focusing intensely on how hidden, progressive internal pathologies express themselves through the body's peripheral extremities before they ever trigger a sudden, catastrophic clinical event. Over my 20-plus years in this field, I have realized that after age 60, your body's biological margins begin to shrink. The physiological reserves that allowed your organs to quietly mask underlying damage in your 40s are no longer as forgiving. When an internal system begins to struggle, the body enters a state of quiet compensation, and your fingernails become one of the very first places where that struggle leaves a visible, undeniable geological trail. Today, we are going to dissect 5 highly specific, distinct nail structural anomalies that peer-reviewed medical research has definitively linked to 5 severe, life-altering conditions that disproportionately strike older adults. These are not obscure, ultra-rare medical anomalies. These are massive, widespread health crises that your primary care physician may simply not have time to screen for during a rushed 15-minute standard consultation. I have structured this breakdown with extreme intent. The 5th and final sign is the most critical. I have saved it for the very end because it is the exact presentation I observe most frequently in patients who present with vague, unexplained cognitive issues, subtle balance shifts, and systemic fatigue that no other doctor can seem to trace. Before we unlock these 5 signs, I need your active participation to help tailor the focus of our community. Drop your exact age in the comments right now and tell me, have you or a loved one ever been diagnosed with a chronic metabolic issue, a circulatory deficit, or an unexplained neurological symptom? Your engagement directly drives this educational mission. Let us step into the clinic and look at what your body is desperately trying to tell you. Let us isolate the very first visual architecture you need to evaluate on your hands today. Longitudinal ridging. If you run the pad of your opposite thumb horizontally across your nail plates, you will likely feel vertical lines running from the cuticle bed straight up to the free edge. Now, if you ask a standard health forum or look at a superficial medical checklist, you will be told that vertical ridges are merely the wrinkles of the nail, a benign, universal byproduct of the natural aging process. And to an extent, that is true. As the decades pass, the nail matrix, the highly active pocket of dividing stem cells hidden just beneath your skin fold, gradually slows its cellular turnover. It begins to produce an uneven thickness of keratin, creating faint, perfectly symmetrical ridges across all 10 fingers. This is standard chronological aging. But as a neurologist with more than 2 decades of clinical tracking, I am trained to look for a completely different, highly pathological presentation. Pronounced asymmetric longitudinal ridging. I want you to hold both of your thumbs directly side by side under intense natural overhead light. Look at the depth of the ridges. Is the surface of one thumbnail relatively uniform, while the other looks like a deeply rutted corduroy road? Is this stark structural disparity accompanied by an increased brittleness, where the nail on that single, specific side frequently cracks, splits, or chips down the center line? When you see a profound structural breakdown of the nail architecture that is strictly localized to one hand, particularly developing over a rolling 12 to 24-month window, you are not looking at normal aging. You are looking at a localized failure of the peripheral neurovascular supply. In deep clinical neurology, this precise asymmetry has a documented, ominous correlation with the prodromal phase of Parkinson's disease. To understand why a movement disorder in the brain would alter the texture of a thumbnail years before a diagnosis, we have to completely reframe what Parkinson's disease actually is. Most people assume Parkinson's begins in the motor cortex or the substantia nigra, the deep brain structure that produces dopamine. This is a massive clinical misconception. In its earliest stages, a period we call the prodromal phase, which can last for 5 to 10 years before a patient ever experiences a classic resting tremor, Parkinson's is fundamentally a disease of the autonomic and peripheral nervous systems. Long before dopamine drops in the brain, misfolded alpha-synuclein proteins begin aggregating in the peripheral nerve networks, specifically attacking the small autonomic nerve fibers that regulate blood vessel diameter, sweat gland function, and microvascular perfusion in your distal extremities, your fingertips. The nail matrix is an incredibly demanding biological engine. It requires a constant, highly regulated, microscopic pulse of nutrient-rich blood and precise neurovascular signaling to lay out a perfectly smooth, resilient sheet of dense keratin. When the autonomic nerves supplying one side of the body begin to fail due to early alpha-synuclein neurodegeneration, the microcapillary beds beneath that specific nail matrix undergo chronic, localized vascular instability. The matrix on that side is starved of stable nutrition. The result is a structural collapse, deep, ragged, vertical grooves, and localized brittle degeneration. Because Parkinson's almost always starts asymmetrically, affecting one side of the nervous system far more aggressively than the other in the initial years, the nail changes mirror this exact lateralization. Think back to a prominent case from my early consulting years, a 63-year-old retired mechanical engineer. He presented to my clinic not because he had a tremor, but because he was frustrated that his dominant right thumbnail had become so deeply ridged and brittle that it kept catching on his clothing, while his left thumb remained perfectly smooth. When I sat him down and conducted a comprehensive prodromal review, the pieces of the puzzle fell into place. His handwriting had quietly shrunk over the past 2 years, a medical sign called micrographia. His right arm didn't swing naturally when he walked. It stayed slightly pinned to his torso. And when I tested his olfactory system, he admitted he had lost his sense of smell entirely nearly 3 years prior, assuming it was just chronic sinusitis. We didn't wait for a dramatic, disabling physical fall or a severe resting tremor. We initiated a targeted neuroprotective protocol, physical therapies, and early lifestyle interventions immediately. Because we read the structural warning signs on his right hand, we were able to intervene at a point where we could aggressively preserve his fine motor skills and overall quality of life for years longer than if we had waited for the classic brain symptoms to emerge. Look at your thumbs right now. If you see an undeniable, deep disparity in vertical ridging between your left and right hands, do not dismiss it as a cosmetic quirk of aging. Take a high-resolution photograph under direct sunlight. Log whether your handwriting has altered. Note if your sense of smell has dulled, and request a dedicated, comprehensive neurological evaluation at your next medical visit. Let us shift our focus to the second critical biometric warning zone: horizontal structural disruptions and dual-tone color zoning. I want you to run your finger vertically from the cuticle up to the tip, feeling for any deep horizontal trenches or grooves cut clean across the width of the nail plate. These horizontal depressions are known clinically as Beau's lines. To understand the profound diagnostic weight of a Beau's line, you have to look at the sheer biological intensity of the nail matrix. The cells responsible for building your nails divide at an explosive rate, ranking among the fastest replicating tissues in the entire human body. Because of this massive metabolic demand, the nail matrix acts exactly like a highly sensitive seismograph, instantly recording any severe physiological shock to your systemic health. When your body experiences a massive, acute crisis, such as a high-grade fever, a severe infection, or major surgical trauma, it enters an emergency survival mode. The brain instantly reroutes all metabolic resources away from non-essential peripheral tissues to protect your vital organs. As a direct result, the nail matrix completely shuts down production. It stops growing entirely. When your body recovers and systemic stress normalizes, the matrix wakes back up and resumes building the nail. But that temporary cellular shutdown leaves behind a permanent physical scar, a deep horizontal groove pressed into the nail plate. Because your fingernails grow at an average pace of roughly 3 millimeters per month, that groove slowly travels forward like a structural timeline. If you see a single Beau's line sitting exactly halfway up all your nails, you can confidently calculate that your body survived a massive physiological shock approximately 2 to 3 months ago. However, as a specialist in long-term systemic diagnostics, a single, isolated groove is not what concerns me. What demands your urgent medical attention is the appearance of recurring Beau's lines, multiple horizontal trenches stacked sequentially at different heights on the same nail, or grooves that continuously form without any history of an acute illness. In older adults, this specific pattern of chronic repeated matrix arrest is a classic, deeply documented clinical marker of underlying chronic kidney disease, CKD. Your kidneys serve as your body's primary filtration plant. When their performance degrades, a trend that accelerates quietly in adults over the age of 60, they lose the ability to clear metabolic waste products from your bloodstream. As these nitrogenous waste compounds build up, the body enters a state of subclinical uremia. Urea and associated uremic toxins are profoundly damaging to highly active, rapidly dividing cells. Because your nail matrix cells are hypersensitive, this toxic buildup continuously poisons the matrix environment, causing it to stutter, stall, and repeatedly shut down production. This chronic metabolic toxicity manifests on your fingers as a wave of recurring horizontal trenches. To make this warning sign even more definitive, early-stage renal decline frequently pairs this structural scarring with a highly distinct color mutation known as Lindsay's nails, or half-and-half nails. When evaluating your hands under natural light, look closely at the color distribution of the nail bed beneath the hard plate. In a textbook presentation of Lindsay's nails, the nail bed is split cleanly into two contrasting color zones. The proximal zone, closest to the cuticle, turns an opaque, milky white or pale pink, completely obscuring the natural vascular color. The distal zone, the upper half closer to the tip, transitions sharply into a distinct brownish red or deep pink band. This dual-tone mutation occurs because chronic renal insufficiency triggers a localized vascular expansion and a profound increase in melanin pigment deposition in the forward capillaries of the nail bed, while the back half becomes completely washed out due to chronic systemic metabolic anemia. The true danger of chronic kidney disease in seniors is that it is completely silent. In its early and moderate stages, CKD causes zero pain, zero obvious urinary changes, and no dramatic symptoms. Millions of older adults live active lives entirely unaware that their filtration rate is plummeting, while their fingernails have been actively encoding the crisis for years. I frequently recall a 71-year-old patient named Margaret who came to my clinic. She had noticed deep, repeating horizontal ripples across her fingernails for nearly 2 years, along with a strange dual-color shift where the tips of her nails looked permanently stained brown. She had dismissed the ridges as a natural consequence of aging and assumed the color was from gardening. Because I recognized the precise overlap of Beau's lines and Lindsay's architecture, I immediately bypassed basic checkups and ordered a comprehensive metabolic panel. The laboratory results were startling. Her estimated glomerular filtration rate, eGFR, the gold standard metric for kidney performance, had dropped into the critical zone of stage 3 chronic kidney disease. We immediately intervened with aggressive dietary modifications, meticulous blood pressure regulation, and a complete overhaul of her prescription medications to eliminate nephrotoxic drugs that were further crushing her kidneys. Because we intervened based entirely on her nail architecture, we successfully halted the progression of her renal decline, entirely preventing the terrifying trajectory toward complete kidney failure and dialysis. Examine the width of your nails right now. If you detect recurring horizontal grooves, or if you see a sharp, distinct color line dividing a pale bottom half from a dark, reddish-brown top half, do not wait for a routine annual checkup. Request a specific, immediate metabolic blood panel from your physician, including serum creatinine and an eGFR calculation. Your filtration system may be counting down. Let us advance to the third critical diagnostic marker, which requires you to alter your perspective entirely. Instead of looking down at your hands from above, I want you to lift one of your fingers up to eye level and look at the structural silhouette of the nail plate from the very side. In a healthy individual, a normal fingernail follows a gentle, convex, architectural path. It forms a soft, downward curving arc that mirrors the natural, rounded cushion of your fingertip. But as we cross the threshold of 60, a dramatic structural inversion can begin to take hold. The lateral edges of the nail plate begin to lift upward. The natural center flattens out, and eventually, the entire center of the nail plate hollows out completely. The nail curves backward, forming a stark, concave basin. This condition is known in clinical medicine as Koilonychia, commonly referred to as spoon nails. To test this right now, take a single drop of water and place it directly onto the center of your nail plate. If the drop stays perfectly pooled in the center without rolling off, your nail has spooned. In adults over the age of 60, the development of Koilonychia is one of the most critical and urgent physical signs a clinician can spot. This is not because the spooning itself is dangerous, but because of the devastating, hidden destruction it signals within the deep structures of the brain and the central nervous system. Koilonychia is the absolute, definitive physical manifestation of long-term, severe iron deficiency anemia. But here is the critical connection that standard medical narratives completely fail to highlight. Iron deficiency in an older adult does not just manifest as physical fatigue or pale skin. In the senior population, chronic iron depletion is a major driving cause of profound neurological deterioration, executive cognitive dysfunction, and rapid memory loss. Tragically, when an individual in their 60s or 70s begins experiencing severe memory fog, difficulty retrieving words, or a sudden inability to concentrate on complex tasks, society, and far too many rushed medical professionals instantly jump to a dark, terrifying conclusion. They assume they are witnessing the irreversible onset of senile dementia or Alzheimer's disease. But in a shocking percentage of cases, that cognitive collapse is actually a completely treatable, entirely reversible metabolic deficit that has been screaming for help through the shape of the patient's fingernails. To understand why your brain completely deconstructs without iron, we have to look past red blood cells and look at neurological metabolism. Iron is the absolute, non-negotiable chemical catalyst required for three massive neurological functions. Myelin synthesis. Myelin is the dense, protective fatty insulation that coats every single nerve fiber in your spinal cord and brain. It allows electrical thoughts to travel at lightning speeds. Without iron, your body cannot maintain this insulation, causing your neural signals to literally short-circuit and slow to a crawl. Neurotransmitter production. The crucial chemical messengers that dictate your memory, mood, and mental processing speed, specifically dopamine and serotonin, cannot be structurally synthesized by your brain cells without a constant high-volume supply of iron. Frontal lobe cellular metabolism. The frontal lobe is the command center of your adult brain. It governs your logic, your memory retrieval, and your processing speed. Its cells have the highest metabolic demand for iron in the entire central nervous system. When your systemic iron stores collapse, which happens frequently and silently after 60 due to age-related changes in gut absorption, the chronic use of acid reflux medications, or hidden gastrointestinal blood loss, the brain is starved of this critical catalyst. Because the nail matrix relies on identical, hyperactive iron-dependent enzymes to build the rigid structural crosslinks within your keratin plates, the matrix collapses under the exact same deficiency, causing the nail to structurally warp and buckle into a spoon shape. The neurological presentation of this iron deficit almost always follows a distinct clinical triad: a crushing, systemic fatigue that sleep cannot fix, a terrifying sense of mental slowing or brain fog, and a severe, agonizing manifestation of restless leg syndrome, RLS, at night. A persistent, crawling, uncomfortable urge to violently move the legs the moment you lie down to rest, which is a direct consequence of iron-depleted dopamine dysfunction in the basal ganglia of the brain. I distinctly recall a 68-year-old patient who was brought into my clinic by her distraught family. Over the preceding 14 months, her sharp, analytical mind had seemingly withered. She was suffering from profound memory lapses, struggled to manage her daily finances, and was experiencing severe nighttime restlessness. Her family was entirely convinced she was in the gripping, final descent of irreversible dementia. When I conducted her physical examination, I immediately bypassed her cognitive testing for a moment and looked directly at her hands. Her thumbnails and index fingers were profoundly concave. Classic, advanced Koilonychia. I ordered an immediate, exhaustive iron panel, including serum ferritin and total iron binding capacity. Her ferritin levels were practically non-existent, We immediately bypassed generic multivitamins and initiated a targeted, high-absorption therapeutic iron restoration protocol under strict clinical supervision. Within 4 months, the transformation was nothing short of miraculous. The dense fog that had locked her mind away completely vanished. Her executive cognitive function scores returned to normal. Her memory sharpened back to its baseline, and her nighttime leg restlessness ceased entirely. Her brain had not been decaying from an incurable disease. It had simply been starving for a basic chemical element. A starvation that her spoon nails had been explicitly broadcasting to the world for nearly 2 years. Look at your nails from the profile view right now. If you see even the earliest signs of flattening or upward spooning, especially if you are fighting an uphill battle against memory fog, exhaustion, or restless legs at night, demand a comprehensive iron and ferritin blood panel immediately. Do not allow your cognitive health to be misdiagnosed when the answer might be written right on the tips of your fingers. Let us now analyze the fourth critical biometric indicator, which focuses directly on the vascular health of your heart. Terry's nails and companion microvascular disruptions. To evaluate your hands for this presentation, I want you to look closely at the overall color distribution of the main body of your nail plates. In a normal, healthy hand, the nail bed displays a uniform, vibrant pink hue from the cuticle all the way to the tip. But when Terry's nails develop, a striking transformation occurs. The entire surface of the nail bed turns an opaque, washed out, milky white or pale gray color, closely resembling the appearance of frosted glass. Crucially, this paleness does not cover the entire finger. There remains one defining pathognomonic structural marker at the very far edge of the nail plate, a sharp, narrow band of deep pink, reddish, or dark brown color sitting right at the tip, measuring just 1 to 3 millimeters wide. This specific presentation is known in cardiovascular medicine as Terry's nails, named after Dr. Richard Terry, who first identified the systemic link in the 1950s. While superficial beauty blogs might tell you that pale nails simply mean you are cold or need better lotion, peer-reviewed clinical research published in cardiovascular diagnostic journals reveals a far more serious reality. The presence of Terry's nails is associated with an odds ratio greater than 6 for underlying coronary artery disease, CAD, congestive heart failure, and advanced systemic diabetes. To understand why a progressive blockage in your heart's arteries transforms the color of your fingertips, we must look at microvascular architecture. Your nail matrix and the underlying nail bed are packed with an incredibly dense network of microscopic blood vessels called capillaries. Because these vessels are so incredibly small and sit at the furthest point from your heart, they serve as the absolute frontline warning system for your entire circulatory network. When coronary artery disease begins to silently restrict your central blood flow, or when early-stage heart failure reduces your heart's total cardiac output, the body immediately prioritizes survival. It restricts blood flow to your most distant extremities to protect your brain and core organs. Over months and years of this chronic, low-level circulatory starvation, the tissue bed beneath your nail plate undergoes structural remodeling. The capillary loops directly under the main plate atrophy and dry up, causing the nail bed to lose its healthy pink blood volume and turn a stark, washed-out white. Meanwhile, the very tip of the nail bed receives a small, concentrated backup pulse of venous pressure, creating that distinct, dark, reddish-brown boundary strip. To make this cardiovascular warning sign even more urgent, this color shift is frequently accompanied by a secondary microvascular phenomenon known as splinter hemorrhages. If you examine your nail plates under direct bright light, look for tiny, thin, dark red or black vertical lines running beneath the surface, looking exactly as if a microscopic wooden splinter is trapped under the nail. These lines are actually tiny linear tracts of blood that have escaped from ruptured, damaged capillaries in the nail bed. Now, if you slam your finger in a car door or drop something heavy on your hand, a splinter hemorrhage is completely harmless trauma. But if you look at your hands today and see multiple, unexplained splinter hemorrhages appearing across several different fingers without any physical injury, you are looking at an active vascular emergency. Classically, in advanced cardiovascular medicine, multiple unexplained splinter hemorrhages are a direct physical indicator of infective endocarditis, a severe, destructive bacterial infection of the inner lining of your heart chambers and heart valves. When bacteria colonize a heart valve, They create tiny septic clusters that break off into the moving blood current. These microclots travel downstream until they slam into the tightest, smallest blood vessels in your body, the capillaries of your nail bed, causing them to instantly rupture and display vertical blood tracks on your fingers. The terrifying reality of coronary artery disease and heart valve infections in adults over 60 is that they frequently develop with zero classic symptoms. Millions of seniors walk around every day assuming their heart is perfectly healthy because they don't have crushing chest pain or a dramatic racing pulse, entirely unaware that their cardiovascular reserves are actively collapsing. I will never forget a 74-year-old patient named George who came into my clinic. George felt reasonably well, though he admitted he had been feeling a bit more fatigued during his evening walks over the past year, which he naturally dismissed as a normal part of getting older. During his physical exam, I immediately noticed that all 10 of his fingernails had turned that unmistakable, milky white frosted glass color with the thin, dark red band pinned to the very tips. I also spotted 3 distinct dark vertical splinter hemorrhages on his left index and ring fingers. Bypassing standard generalized advice, I immediately ordered an urgent echocardiogram and a comprehensive cardiac stress test. The results were a massive wake-up call. George was suffering from advanced multivessel coronary artery disease, an early-stage congestive heart failure that had been quietly eroding his heart muscle for close to 2 years without a single episode of acute chest pain. Because we read the clear microvascular warnings written on his fingertips, we were able to immediately initiate a targeted cardiovascular protocol, including advanced beta blockers, ACE inhibitors, and precision lipid management therapies. George is alive, active, and thriving today, completely avoiding what would have undoubtedly been a sudden, catastrophic, and potentially fatal heart attack. Examine the color of your nail beds right now. If you see a stark, frosted white paleness across the plate paired with a distinct dark strip at the very tip, or if you spot unexplained dark vertical lines running beneath the surface, do not wait for symptoms to worsen. Treat your nails as a live heart monitor and contact your physician this week to request a comprehensive cardiovascular evaluation, including a 12-lead EKG and a diagnostic echocardiogram. We have finally arrived at the 5th and final sign. As a clinical neurologist with over 2 decades of experience, this is the visual presentation that concerns me most deeply. It is the one I see most frequently in older patients who have been bounced from doctor to doctor for years, trying to find an explanation for a terrifying constellation of vague, mysterious neurological symptoms. I want you to look right now at the very base of your thumbnails, right where the nail plate emerges from the cuticle skin fold. Do you see a distinct pale white crescent-shaped arc sitting there? That small half-moon is called the lunula. The lunula is not just a quirky cosmetic feature of human anatomy. It is the only visible portion of your nail matrix, the engine room where specialized stem cells are working around the clock to synthesize the tough keratin layers that form your nail. In a healthy adult, this white half-moon should be sharp, bold, and clearly visible on both of your thumbs. It is usually visible on your index fingers, frequently visible on your middle fingers, and variable as you move down to your pinkies. That is your healthy baseline. Now, look incredibly closely at your thumbs under direct daylight. Has that white crescent shrunk down to a tiny microscopic sliver? Has it receded entirely beneath the cuticle skin fold, leaving nothing but a uniform pink sheet from top to bottom? If your lunulas used to be clearly present and have now quietly vanished, you are looking at a clinical phenomenon known as absent lunula, or nail matrix atrophy. In adults over the age of 60, a disappearing lunula is a profound physical warning that the metabolic rate of your nail matrix has plummeted. The matrix cells are starving, losing their ability to divide and maintain their structure. While superficial health guides might dismiss this as a harmless quirk of getting older, deep clinical literature reveals that this specific matrix shutdown is one of the earliest, most reliable indicators of severe vitamin B12 deficiency and its devastating downstream consequence, subacute combined degeneration of the spinal cord. I recognize that subacute combined degeneration is a heavy, intimidating medical phrase. Let me break it down for you with absolute simplicity. Vitamin B12 is the absolute non-negotiable molecular key required to maintain the structural integrity of your central nervous system. Specifically, Your body cannot produce or repair myelin without it. As we discussed earlier, myelin is the dense, protective insulation that wraps around your nerve fibers, precisely like the plastic coating around an electrical wire. When your systemic B12 levels collapse, that protective insulation literally begins to dissolve. This dissolution strikes two specific targets: the peripheral nerves in your hands and feet, and the massive vertical nerve tracts inside your spinal cord that connect your brain to the rest of your body. The tragedy of B12 deficiency in seniors is that it is incredibly common, yet completely misunderstood. Most people assume that if they eat meat or take a generic multivitamin, they are completely safe. This is a massive, dangerous misconception. After the age of 60, your stomach lining naturally undergoes structural changes, drastically reducing its production of intrinsic factor, the specialized protein your gut absolutely requires to bind and absorb B12 from your food. Furthermore, millions of older adults take incredibly common daily medications that completely paralyze B12 absorption as a side effect. If you take metformin for blood sugar management or a proton pump inhibitor like omeprazole for acid reflux, you are actively blocking your body's ability to absorb this vital nutrient. Because the rapidly dividing stem cells of your nail matrix require a massive, continuous supply of B12 to maintain their intense cellular division, a drop in this vitamin causes the matrix to instantly atrophy and shrink. The white half-moon of the lunula pulls back and disappears from view long before the damage to your spinal cord is large enough to show up on an MRI or a standard neurological screen. When the spinal cord insulation begins to actively degrade from this deficiency, it triggers a very specific, progressive timeline of neurological symptoms that almost nobody connects to their nails. The sensory phase. It starts with a persistent, symmetrical numbness or a pins and needles tingling sensation in the tips of your toes or fingers. The coordination phase. As the spinal cord pathways thin out, you begin to lose your spatial awareness. You might find yourself unsteadily stumbling in the dark, misjudging a step, or noticing that your balance feels slightly off when you turn around quickly. The cognitive phase. Because B12 is also vital for brain metabolism, its absence triggers profound mental fatigue, sudden mood shifts, and a terrifying memory fog that leaves you struggling to recall everyday words. During my years in clinical consulting, I evaluated a 67-year-old gentleman who was brought to me because he had developed an unsteady, shuffling gait and was constantly complaining of a burning, tingling numbness in both of his feet. He had already been evaluated for standard diabetic neuropathy, but the tests were completely inconclusive. He was terrified he was losing his mobility permanently. When I sat him down and closely examined his hands, I immediately saw that the lunulas on his thumbs and index fingers had completely vanished. They were entirely absent, replaced by a dull, faded pink tissue bed. I asked him if he was taking any long-term medications, and he confirmed he had been on a high-dose proton pump inhibitor for acid reflux for over 5 years. I immediately ordered an advanced neurological blood panel measuring serum B12, methylmalonic acid, MMA, and homocysteine, which are hyperspecific markers of cellular B12 starvation. The results confirmed our structural suspicions. His cells were in a state of advanced, acute B12 starvation. We immediately bypassed oral supplements, which his gut could no longer absorb, and initiated an aggressive regimen of therapeutic intramuscular B12 injections to deliver the nutrient directly into his bloodstream. The clinical turnaround was profound. Within months, the myelin insulation around his spinal cord began to actively rebuild. The burning numbness in his feet entirely receded, his steady, confident stride returned, and the heavy mental fog lifted from his mind. His nervous system had been on the precipice of irreversible spinal cord damage, a crisis that his disappearing half-moons had been desperately trying to signal for nearly 2 years. Look at the base of your thumbs right now under a clear light. If those white half-moons have shrunk to a faint line or disappeared entirely, especially if you are quietly battling tingling hands, subtle balance changes, or a persistent memory fog, do not let it slide. Insist that your physician order a comprehensive B12 evaluation, including methylmalonic acid and homocysteine levels. Your mobility and your spinal cord health may depend entirely on what you do with that visual information. Now that we have comprehensively dissected these 5 severe systemic pathologies, We must transition from passive theory into immediate, actionable clinical practice. To effectively utilize your fingertips as an active biometric monitor, you need a precise, standardized diagnostic protocol. You must understand how to separate an isolated, insignificant blemish from a true structural red flag. The very first diagnostic baseline you must establish right now is the physical texture of your nail plates. When a structural abnormality is benign, it typically expresses itself with absolute symmetry across all 10 fingers. For example, if you detect faint vertical lines that look and feel identical on every single nail, your matrix is simply experiencing uniform chronological aging. However, pathognomonic changes, meaning structural mutations that point directly to an active internal disease, are notoriously erratic. They present with striking asymmetry, cluster aggressively on specific fingers, or run completely counter to your past physical baselines. If a ridge, a color split, or a shape mutation develops rapidly over a 6 to 12-month window on just one hand, your body is actively signaling and localized microvascular or neurological breakdown. To bridge this gap completely, I'm going to teach you a legendary diagnostic test that vascular specialists use globally to instantly grade your peripheral circulatory system. It requires zero medical equipment, takes exactly 10 seconds, and you can perform it on yourself right now while reading this. It is called the capillary refill test. I want you to place your dominant hand flat on a table, holding it roughly at the level of your heart. Take the thumb of your opposite hand and press down with firm, steady pressure directly onto the center of your index fingernail. Hold that intense pressure for exactly 2 seconds. As you press, you are physically forcing the blood out of the microscopic capillary networks beneath the nail plate. When you look down, you will see the nail bed flash a stark, bloodless white. Now, I want you to abruptly release your thumb and immediately count the exact seconds it takes for the vibrant, natural pink color to flood back into that tissue bed. Let us break down the internal mathematics of your result with absolute clinical precision. The optimal zone, under 2 seconds. If the pink color returns instantly, like a snapping rubber band, your microvascular circulation is performing beautifully. It proves that your central cardiac output is strong, your peripheral blood pressure is adequate, and the microscopic vessels supplying your furthest extremities are completely flexible and highly responsive. The borderline/sluggish zone, 3 seconds. If the white patch lingers for a full 3 seconds before fading, your peripheral circulation is beginning to lag. This is a common early indicator of systemic dehydration, dropping ambient temperatures, or early-stage arterial stiffening. The critical warning zone, 4 seconds or longer. If you count 4 to 5 seconds or more before the nail bed recovers its pink hue, and you get this exact same sluggish result across multiple different fingers while sitting in a warm room, you are looking at a major clinical warning sign. A persistently delayed capillary refill test in an adult over the age of 60 is a powerful physical indicator of deep-seated circulatory distress. It proves that the physical volume of oxygenated blood being pumped by your heart is dropping, or that the arterial pathways leading to your hands have become severely narrowed by atherosclerotic plaque. In clinical tracking, a chronic 4-second refill is heavily correlated with undiagnosed atrial fibrillation, a chaotic, irregular heart rhythm that allows blood to pool and clot inside the heart chambers, serving as the leading driver of sudden, devastating ischemic strokes in seniors. To turn this single test into an airtight diagnostic screening framework, you must pair it with a secondary physical assessment, the thermal cheek alignment. Take the backs of your fingers and press them firmly against your cheek. Your hands should naturally match the warm temperature of your face. If your fingers feel noticeably cold or icy to the touch while sitting in a comfortable warm room, you have confirmed a state of chronic peripheral vasoconstriction. When you see a persistently delayed capillary refill paired with chronically cold hands and any new, unexplained heaviness or cramping in your calf muscles when walking upstairs, you have identified a classic vascular triad. This is the explicit physical footprint of peripheral artery disease, PAD. The identical calcified plaque that causes catastrophic blockages in your heart's coronary arteries is actively choking off the blood supply to your limbs. Do not allow these microvascular warnings to pass by unrecorded. Tonight, I want you to take your hands to a clear window under natural, indirect daylight. Execute the capillary refill test on 3 separate fingers. Count the seconds honestly and note down the results. By documenting these subtle shifts today, you create an invaluable clinical roadmap that allows your physician to intervene years before an asymptomatic vascular deficit transforms into an absolute medical emergency. Now, let us establish the absolute, non-negotiable boundaries of how you must process this information. Everything we have dissected today regarding microtextures, dual-tone color patterns, horizontal grooves, and matrix variations is designed with a singular, strict mandate to transform you from a passive observer into an informed, active advocate for your own health. I must state with absolute clarity that the insights shared in this presentation are for educational and informational purposes only. Under no circumstances should you ever use these structural nail findings to diagnose yourself, alter your existing prescription medication dosages, or bypass professional medical interventions. A single nail sign observed in isolation is a powerful clinical clue. It is not a final diagnosis. To synthesize an accurate, safe, and definitive medical conclusion, a qualified physician must cross-reference these external markers with your comprehensive personal history, a battery of advanced laboratory blood panels, your current medication list, and a complete physical evaluation. Your job as the patient is not to diagnose. Your job is to notice, to document, and to speak up. Do not talk yourself out of bringing these observations into the exam room because you fear looking overly concerned about something cosmetic. If you examine your hands today and discover a single anomaly, such as deep vertical lines or a slower capillary refill, simply document it and bring it up at your next regularly scheduled physical checkup. But if you look at your hands right now and discover 2 or more of these signs presenting simultaneously, do not sit back and wait for a distant annual appointment. Call your primary care physician's office this week, clearly describe the physical shifts you have noted, and request a dedicated diagnostic evaluation. Your fingernails have been sitting quietly at the ends of your fingers for your entire life, acting as an unceasing, dedicated ledger of your internal health. They take precise, daily notes on the velocity of your blood flow, the metabolic activity of your organs, and the structural health of your central nervous system. The only piece of the puzzle that was missing was someone taking the time to show you how to decode what they were actively writing. Now you hold that clinical key. My name is Dr. Liam Cooper, and I want to thank you for spending your valuable time with me today. If this advanced, deep dive approach to preventative education has empowered you to view your body through a clearer lens, please hit the subscribe button, leave a like, and share your thoughts in the comments below. Forward this information immediately to someone you love, because the next person who looks closely at their hands tonight under a living room lamp might spot a subtle warning sign, make a timely call to their doctor, and completely alter the course of their life. Take care of yourselves, stay vigilant, and I will see you in the very next video.